Now I would like to invite the second presenter of today's session. I would like to invite Professor Irfan Malik. He is Professor and Head of Department of Pulmonary Critical Care and Sleep Medicine at University College of Medicine and Dentistry, University of Lahore. He is also the Regional Advisor to Royal College of Physicians, Glasgow. Professor Dr. Irfan Malik.
Bismillahirrahmanirrahim. Thank you so much. Thank you, Pakistan Society of Internal Medicine, for inviting me here. And giving me a very unique topic for which I have to go through a lot of literature. I was very comfortable with a talk on smoke, sleep apnea, asthma, but I was asked to talk on a topic. So, approach to a patient to shortness of breath. The most difficult debate among us. For those who don't know me, I am Dr. Irfan Malik, currently working as Professor of Pulmonary Medicine and Critical Care Medicine at University of Lahore. If I ask you people to hold your breath for some time, close your eyes, there is no cough, no wheeze, no shortness of breath, then the fight will going on inside you. Could it be cardiac? Could it be respiratory? Dyspnea is not a diagnosis, by the way. It's a warning for everybody, for all of us. My learning objective starts from the definition and then classification, diagnosis, and little bit about the management, as time is too short and topic is too vast. So if we go through the literature and see where definition is written in our two society guideline, one is American Thoracic Society guideline and second is ERS Thoracic guideline, they mention the definition of sleep apnea. It is primarily breathing discomfort, that is the consensus in both the definition and the mismatch between ventilatory demand and meet of the demand. This is the consensus in both the guideline, but in ERS, Respiratory Society, tell us there must be an influence of physiological, psychological, social and environmental fact among them. Now look at the burden of shortness of breath. 10% of emergency cases belong to the shortness of breath, and it is among the top 5 presenting symptoms in medical care. 25 to 30% patients who are hospitalized, they are having this complaint of shortness of breath. So if we dissect it further, respiratory medicine account more than 50% of the cases of shortness of breath, and cardiac cases account almost 40% cases. Rest of the cases belong to either psychogenic or neurologic. So I will focus mainly on these two parameters. One is cardiac, second is respiratory parameters. So these are called as a big 90: asthma, heart failure, ischemia, COPD and pneumonia. Rest count less than 10%. How we classify the shortness of breath? It is classified according to the time. One is acute over minute and hour, second is subacute over days and week, and third one is chronic. So acute means it's an emergency. You have minutes to hour to decide. Patient will have a shortness of breath, and oftenly these are life-threatening cases and require immediate evaluation and management. There is a little bit about subacute shortness of breath, as either they will go towards the final diagnosis or patient usually self-settled. In chronic shortness of breath, usually shortness of breath is more than 8 weeks. It slowly progresses and usually related to chronic cardiopulmonary or neuromuscular disorders. I will not go to physiology in depth, but mostly these three systems are involved. One is controller, and the controller is basically your brain, and then there is a ventilatory pump, and at the end there is a gas exchange mechanism. So controller brainstem, from brainstem efferent signal goes to the ventilatory pump, that are your muscle, your chest wall and airway. At the end, alveoli and capillaries play a very important role in gas exchange. So what is the stepwise approach? If a patient comes to you, you will take an history, and these are the red flag signs: stridor, wheeze, crackles and murmur. After that, you can send CBC, metabolic profile, thyroid if you suspect, and based on your primary investigation, which is X-ray chest, you can dissect your patient, either the patient belong to the pulmonary or belong to the cardiac cases. But always listen the patient itself, what patient is saying. There is a common saying, patient को सुने, patient आपको history बताता है कि उसका diagnosis क्या है. Some words are very classical. Patient is having chest tightness, more in favor of bronchoconstriction, more in favor of asthma. Patient is feeling increase in workload, this is more in favor of myopathy. If patient is having air hunger, it favors that patient is most likely suffering from some heart failure and less likely asthma. Rapid and shallow breathing is a feature of interstitial lung disease. Suffocating, smothering is a feature of alveolar filling, like in pulmonary edema. If patient is feeling heavy, breathing become more when patient do exercise. It could be deconditioning, which is a very, very new word for me, by the way. We classify dyspnea on the base of this Brock dyspnea scale. Patient kitna short of breath hai while doing Shortness exercise, too short of breath to change cloth. And it will tell us about the impact, and it will tell us about the mortality. Patient kitna intense short of breath hai, this Brock dyspnea scale will help us in this. So on clinical examination, you will assess for jugular venous pressure. On chest examination, there could be wheeze, crackles, there could be hyper-resonant auscultation. So your first investigation is X-ray chest, followed by ECG and pro-BNP or BNP if it is available, initially to diagnose a case of shortness of breath. So starting from saturation, followed by X-ray and then ECG, spirometry if available, you do some blood test initially to differentiate shortness of breath. So if we go systematically, so hemoglobin may help you if patient is having anemia, thyroid in some classified patients, but glucose, urea, creatinine, electrolyte will help you that the cause of shortness of breath. In pulmonology, the literature mentions spirometry, but I will focus more on X-ray chest. But there are some red flag signs, like if saturation is less than 90, this means you may go for ABGs. In cardiac evaluation, X-ray chest again help us, by the way, followed by ECG and very important BNP less than 100, less likely, more than 400, most likely that patient is suffering from cardiac disorder. So in cardiac disorder, the mechanism is pump failure, so fluid is accumulated. In respiratory disorder, the mechanism is primarily obstructive. So in cardiac disorder, it is usually wet lung, you may have gallop, you may have peripheral edema. In respiratory disorder, you will have hyperresonant airways, you will hear wheeze, maybe silent chest in respiratory medicine. So in acute shortness of breath, in cardiac medicine, you may find patient with having acute MI, heart failure, and cardiac tamponade. In respiratory system, most common disorder is usually asthma, followed by infection and upper airway disorders. See, I ask you people, what should be the first line of test? X-ray or ECG? Anybody? X-ray करवाएं या ECG करवाएं? Both. But literature changed now. What about this device? Ultrasonography is now helping us a lot. There is a study published in a journal who described this blue code. Blue code means you do ultrasound in 12 areas of lung, followed by a short echo, along with IVC. These three ultrasonographic tests will help you in differentiating the etiological factor. So look at the study. It says you can diagnose your case in 20 minutes, and if you don't follow this cascade, usually it will take more than 4 hours to diagnose a case. This is the ultrasonographic picture. In this dry lung, you can see these A line. The student who are doing ultrasonography, they can well imagine these A line are too much in one probe size. So these are favoring that patient is having hyperinflation. In the other image, these are the B line. If there are 3 or more than 3 B line, you can say that this is a wet lung. And B line, along with B line, you can see easily that patient is having consolidation on ultrasonography. So if there is obstruction, you do spirometry, you can go for DLCO, for cardiac, you do echocardiography. But there are some red flag signs when you are dealing with acute shortness of breath. If patient present with shortness of breath, if there is altered mental status, there is cyanosis, tracheal degradation, and unilateral absent breath sound. This is very, very important slide as far as acute shortness of breath is concerned. If there is upper airway obstruction and you are hearing the stridor, this means patient is having some upper airway obstruction, so tracheostomy is required. If there is absent breath sound, this means there is pneumothorax. In embolism, patient may be okay as far as CT is concerned, but patient is oxygen dependent, and along with that, there will be tachycardia. So chronic shortness of breath, again, we will start with simple test, that is X-ray chest. In X-ray chest, if CT ratio is enlarged, then you can suspect that patient is having cardiac issues. After X-ray, you will do ECG, followed by pro-BNP test, and followed the cascade for cardiac issue. If there are bilateral, bibasilar crackles and shaggy heart border, patient having loss of lung volume, you can suspect pulmonary parenchymal disease, that is interstitial lung disease. If it is hyperinflated, most likely this is a case of obstructive airway disease. If there is blunting of angle on one side, it means pleural effusion. If both sides, this means most likely it is a cardiac disease. And if you are unable to find anything, focus on musculoskeletal. Kyphosis is a very important factor in causing shortness of breath. Diaphragm, very important factor in causing shortness of breath. So I will not go to the cardiac discussion much, as Professor Mohyuddin Saab is sitting here, so he can talk more on these. So in cardiac cases, ECG followed by echocardiography, but there is one test which can help us, that is pro-BNP. In respiratory system, spirometry help us a lot. If there is obstruction followed by reversibility, it can differentiate between obstructive airway disease. In restriction, we do DLCO, but by the way, unfortunately, this is not available. So in restriction, usually we do 6-minute walk test so that it can help us in differentiating interstitial disorders. If spirometry is normal, it doesn't mean it rule out respiratory disorder. You may need bronchial provocation test. You may need DLCO. If all tests are normal, as far as spirometry is concerned, then patient may be a case of cardiac disorder. And now, this is another important slide. You may find a patient who is having recurrent shortness of breath because of anatomical issue, like vocal cord dysfunction, like goiter in the neck, like asthma, and in abdomen ascites because of recurrent accumulation of ascites, because of diaphragm paralysis. Again, I am repeating it because I have seen a case today again who was being diagnosed as a case of pneumonia, and he is a spot diagnostic case of diaphragm paralysis and neuromuscular disorder. And at the end, if patient is having some arrhythmias, some valvular disorder, that shortness of breath occur recurrently. So in acute, you have bronchospasm, pulmonary embolism, or pneumothorax. In chronic respiratory disorder, you have COPD, ILD, asthma. In cardiac acute disorder, you may have arrhythmias and flash pulmonary edema. In chronic, you will have heart failure and valvular disorder. But you may find patient, despite everything, you unable to conclude your diagnosis. So what you will do? Immediate ABC, and if arrest is there, you will intubate the patient. And after that, your first test will be X-ray chest and vitals, and most importantly, please incorporate ultrasonography in them. After ultrasonography, if there is B line, I will not go in depth, it is most likely cardiac. But remember one thing, B line could be there in patient with interstitial lung disease. If there is A line and A line is increased, it is most likely emphysema. And if there is no sliding sighting, this means this patient is having pneumothorax. So HRCT echo may help us. But remember, these are the 5 big dominating etiological factors in shortness of breath: asthma, COPD, myocardial dysfunction, and obesity. So management start from simple oxygen in some patient to diuretics to bronchodilator, and then rehabilitations and opioid if required. So listen the patient. If patient is saying there is air hunger, there is chest tightness, it's a clue. If BNP, spirometry and SpO2 is normal, this may give you a clue that patient is not having any respiratory disorder and you have to go for advanced testing. So never skip X-ray and spirometry if available, and pro-BNP too. And if there is something missing, ultrasonography will help you a lot. Thank you so much for patient listening.
Thank you very much, Professor Irfan, for telling in detail the approach to shortness of breath.